Good morning. All right. This is the Oregon Health Authority, and we are here today with the hospital staffing team for the Professional Technical and Service Staffing webinar. I'm Anna Davis. I am the hospital staffing and acute care regulation manager, and with me is
Kimberly Volker. I am the hospital staffing policy analyst responsible for investigations. And before we get started today, we do want to give people a little reminder. We will be accepting questions to answer at the end of this. You can send questions throughout the webinar. We won't answer them till the end. But when you do send questions, we have a designated spot for that. It's the co-host marked questions here in all caps. So please do indeed send those to questions here. That is our wonderful Tip McIntosh. She is helping us today with the questions. If you send it directly to myself or Anna, there is a good chance we won't be able to see it as we are navigating multiple screens and looking at the questions that come in via Tip. So thank you.
all right. And also a reminder, this webinar is being recorded, and we will be posting it on our website within the next week. It may be a little bit delayed because of Thanksgiving, but we will post that online on healthoregon.org/nurse staffing. That website is going to be having some changes soon, and we'll send that out on the listserv. So if you aren't already on the listserv, you can go to that website and get on the listserv, and that way you'll get announcements of future webinars and also information about when the website changes and other resources we have available.
And I will say, if you're here thinking, wait, I'm here for professional, technical, and service staffing, and you're a little surprised about the link for the website, you are still in the right spot. We are still talking about professional, technical, and service staffing. We still have that old URL for our hospital staffing page.
All right. So first, I just want to note we have a dashboard that's on that hospital staffing website, and that we update every 2 weeks. And so I always like to highlight that. That shows how many complaints we have received since this law took effect in September of 2023, and that's 2,567 complaints. We updated this dashboard on Monday, so this is really fresh data, and 2,287 of those complaints have been received since June 1st of this year. And we currently have 505 complaints under investigation. Many of those complaints are bundled, so we will investigate multiple complaints against a single hospital in a single investigation, up to 15 different complaints bundled together. But 505 complaints are currently under investigation. 215 complaints have been investigated. Those are completed. And 125 of those resulted in a finding that there was a situation of non-compliance. These are all of these numbers relate to hospital nurse staffing, because the professional, technical, and service staffing have not started yet. Starting in January of 2025, professional, technical, and service staff will be included in this dashboard. So these are the things we're going to talk about today. We'll talk first about the statutory definitions. That will include professional, technical staff, service staff. Then we'll talk about the staffing committees and combined committees as an option. We'll talk about staffing plan requirements, some staffing plan language. We'll talk about the enforcement process, and then we'll talk about the staffing plans that get posted on the OHA website. And after that, we will be answering questions, both those submitted in advance and those that are submitted while we're speaking today. Our presentation takes about 30 minutes, and so then we will have questions after that. So these are the statutory definitions. Professional staff is defined in the statute as professional workers as defined in a collective bargaining agreement, or if no collective bargaining agreement exists, by the chief executive officer of the hospital or the chief executive officer's designee, consistent with the National Labor Relations Board regulations. Technical staff is defined in statute. It's going to sound really similar as technical workers as defined in a collective bargaining agreement, or if no collective bargaining agreement exists, by the chief executive officer of the hospital or the chief executive officer's designee, consistent with the National Labor Relations Board regulations. Okay, and then service staff, also going to sound really similar, and that means service workers as defined by a collective bargaining agreement, or if no collective bargaining agreement exists, by the chief executive officer of the hospital or the chief executive officer's designee, consistent with National Labor Relations Board regulations. So, what does that actually mean? Who are we talking about? Professional technical staff can be lab techs, surgical techs, respiratory therapists. These are just some examples. There can be all kinds of people within this category. But I do want to note that staff included in this definition may vary by hospital, because as we noted on the prior slide, it's based on either a collective bargaining agreement, or if there is no collective bargaining agreement that defines them, then it's the CEO of the hospital. So at one hospital, a respiratory therapist may be included in the professional technical staffing plan. And at another hospital, that same respiratory therapist who goes and works there may not be included in the professional technical staffing plan.
And I'll say those examples that we have there, the lab techs, surgical techs, and respiratory therapists, that definitely falls into that example of it may be in one plan and not in another. The reason why we've included these as examples is because that's what we've heard from some hospitals of who they're likely to put in to these categories. But
we definitely have heard a broad range of who could be included.
Exactly.
Service staff. Some examples we've heard are environmental services and dietary services. And again, these are just examples, and it's really going to be dependent on the collective bargaining agreement at that hospital. And if there is no collective bargaining agreement, then it will be dependent on the CEO. And again, staff included in this definition may vary by hospital. So environmental services at one hospital may be included in the service staffing plan, and at another hospital, they would not be included. So there are two, so we're going to talk about two committees, but they are remarkably similar. We have the Professional Technical Staffing Committee and the Service Staffing Committee. And the requirements for the Professional Technical Staffing Committee are in Oregon Revised Statute 441775. And for the Service Staffing Committee, it's in 441776. And in both of those situations, both the committee requirements and the plan requirements are in that statute. Both the Professional Technical Service and Service Staffing Committee have to be in place by December 31, 2024. Each committee consists of an equal number of staff members who work at the hospital who were covered by that staffing plan and managers. So only professional technical staff members and professional technical managers can be on the Professional Technical Staffing Committee. Only service staff members and service staff managers can be on the Service Staff Committee.
And I will say, perhaps while we're here, we can oh, never mind. I am getting ahead of myself.
All right. So the operational requirements for those two staffing committees are similar to the ones for nurse staffing committees in terms of how members are selected. So if there is a union at the hospital, the union organizes the selection process of the professional technical staff and then or the service staff. If there's no union, then it's a process by which the folks who are covered by that staffing plan are voting on who would be on the staffing committee. And the hospital administration always picks the management members of that staffing committee. So they don't necessarily have an election. It's up to the hospital administration for how they're going to pick those managers. The each staffing committee, whenever they meet, has to have a quorum. A quorum is 50% plus one. So if you have a professional technical staffing committee that has 12 members, you would need to have 7 members present in order to have a quorum for a meeting. And that could be 6 managers plus 1 professional technical staff member. That's not necessarily a great division there, but that would be a legal quorum.
Any combination that gets you to that 50% of the total committee members, plus one.
Plus 1. In contrast, you also have the equal voting requirement, which is when you have a meeting that has a quorum, only an equal number of each side can vote. So if you had a meeting that had 1 service staff manager and 6 service staff members, and this is a committee of 12, so you've got 7 people present, only 1 service staff member and the 1 service staff manager can vote, because whenever you vote, you have to have an equal number of both sides voting, and you can't have an unequal number voting.
And I know that the nurse staffing committees got to practice this more under the old law, that there is usually a process by which the side where not everyone is voting would decide who gets to vote that time. That way it's not always, well, this person sits out. This person never gets to vote if we have extra.
And often that is not something that we control. Yeah. That's something that the staffing committee would determine. Often they put that in their charter so that they can always rely on that. And these staffing committees have to meet at least 3 times a year. So Oregon Revised Statute 441777 allows the Nurse Staffing Committee, Professional Technical Staffing Committee, and or Service Staffing Committee to all be combined. And combined committee operations means they have joint meetings, but they have separate co-chairs and separate voting. And the nurse staffing plans, professional technical staffing plans, and service staffing plans cannot be combined. Separate plans must still be approved for each staff type. So we're going to talk about some plan requirements. Both the professional technical staffing plan and the service staffing plan requirements are enforceable on December 31, 2024. So you have to have a committee on that date and you have to have a plan. In reality, you may have your committee meeting before that so that by that date you have an approved plan. Under both the professional technical statute and the service staff statute, they have the plans that are approved need to be consistent with the approved nurse staffing plan and take into account the other either professional technical or service staffing plan. They don't need to have the same terms because they cover different groups of people, but they need to not be in conflict with one another. Specifically, when developing the professional technical staffing plan and the service staffing plan, the committees need to consider the hospital census, the location of patients, patient types and acuity, national standards, if any, for this specific kind of staff, the size of the hospital and square footage, ensuring patient access to care, and feedback received during committee meetings from staff. Staffing plans can only be enforced by OHA when they include language that's written as required in the staffing plan. We can usually enforce staffing levels that are described as required, mandatory, maximum ratios, minimum numbers, and staffing levels that must or shall. We are often unable to enforce staffing levels described as recommended, ideal, core, allowed, staffing levels may, staffing guidelines. We saw one recently where it was described as typically. That's
Mhm.
not really enforceable.
Sometimes, or guidance, those sort of things. If it's language that's really reflecting more of that, essentially more wiggle room, essentially, that's probably going to fall on the right-hand side of that column, where we're not going to be able to enforce it as a required level. That left-hand side is really where the enforcement happens.
Okay, and speaking of enforcement, we can only investigate complaints of violations listed in ORS 441792. So there are a lot of requirements in the law, things like what has to be in the staffing committee charter, or the minutes that a staffing committee keeps, or requirements of what gets considered in formulating a staffing plan. We can only enforce the requirements that are specifically listed in 792. And for professional technical staff and service staff, the things we can enforce are, and again, starting December 31, failure to establish a professional technical or a service staffing committee, failure to create or adopt a staffing plan, failure to comply with the staffing level in a professional technical staffing plan or service staffing plan, and the failure is not a permitted deviation, and the failure to release professional technical staff members that are part of that staffing committee or service staff members that are part of that staffing committee to attend a staffing committee meeting. OHA will investigate complaints submitted before June 1, 2025. OHA is only able to enforce civil penalties for violations of ORS 441792 that occur on or after June 1st of 2025. So we're investigating things now, but unless an incident occurs on or after June 1 of 2025, that incident would never be subject to civil monetary penalties. So when staffing plans are completed, the hospital submits those to OHA, and OHA is required to post those on our website. We are required to post the plans we receive. We don't have authority to review the plans for compliance prior to posting, and the hospitals are responsible for submitting plans that are approved, current, complete, and compliant. And hospitals, we have a link on our website where hospitals can submit those plans. You submit one kind of plan at a time. So nurse staffing plan, you submit all the nurse staffing plans for the hospital in one PDF. Professional technical staffing plan, all of the professional technical staffing plans that a hospital has get put into one PDF by the hospital and submitted to us, and same with service staffing plans.
And if you have an update later in the year and you update just one unit, you're still bundling all of those service staffing plans together and sending that to us, because there's about 70 of you, 70 hospitals, but also we don't know necessarily what all is getting changed out for each hospital, because 67 hospitals, all of you with multiple units and professional technical nursing and service, that's a lot. So we're asking the hospitals to, to let us know what is all of the plans of that type for your hospital. So we're not going to accidentally take something out that shouldn't be out.
We do not rely on those posted plans in our complaint investigations. Instead, during the investigations, we request and receive from the hospital the plan and information about plan adoption relevant to the complaints under investigation. And so it's what we receive in that investigation that we rely on. And the hospitals are responsible for submitting those updated plans to us, including updates made after an investigation.
And to really explain a little bit of that third bullet point, some of that rationale too is that the individual has 60 days to submit a complaint. And we would then review it. Once we determine that's valid, we have 30 days to start an investigation. In that period of time, the plan might have been updated, and a new plan may be on the website. but we're still going to, during an investigation, we're going to look at the plan that was in place at the time of that complaint. And that's what it gets measured by.
So, for example, if somebody files a complaint about an incident that occurred on September 1st of 2024, we're going to ask the hospital, give us the plan that was in effect on September 1st of 2024. If that hospital adopted a new plan on September 15th of 2024, that's not the one we're going to look at because that wasn't the one in use at the time. And while we are talking about enforcement, we can't accept the complaints about professional technical staff yet or service staff. Again, that's December 31, but we have already created the complaint form that people will use to submit those complaints. And as we did with the nurse staffing complaint form, we actually want to get feedback on this to make sure that our questions are phrased right and that we'll be able to get useful information from the complaints we receive. So we're going to put in the chat the link to our sample complaint form. That will be open until December
2nd at 5 p.m.
Okay.
And you can take that multiple times if you want to go back and you want to try it again or look at a different aspect of it. You can go through it as many times as you want before December 2nd, 5 p.m.
It's not for any real complaints. It's for submitting pretend complaints, but to see what that complaint form is like and to give us feedback on that form. And then we'll take that back and review it with the attorneys at Department of Justice who give us guidance. And then we will be able to see if there are any changes we need to make. Those complaint forms are very similar to our hospital nurse staffing complaint form, so it is based on that, but we are always gathering new information about what do we need to change and are we phrasing our questions in a way that people can understand them. So there are places on the complaint form sample that we're sending out that that provide an opportunity to give feedback. Once we have the real complaint form, we don't have places for you to give feedback about the form itself.
And we do have two forms. They're very, very similar, but we do have one for professional technical staffing. We have one for service staffing. Those are both in the chat now for you to be able to access. I will say one of the things that's really helpful too is we have put skip logic into the forms. We do that for the complaint forms, the nurse staffing form, to make it so you really only have to focus on the areas related to your complaint. If you're going through this and you find, oh, I think there's an error with the skip logic because I didn't mean to go to this place, that is a great thing to know at this stage. I think we're good on all of the skip logic. I think we caught all of it, but always good to know if you see something that looks like a mistake.
Okay, and so with that, we are now going to start answering questions, and we received questions in advance, and we are also getting live questions.
And just another reminder, if you have questions, send that to the all caps questions here. If you send a question to Anna or myself, so if you send it, I'm right now it's a dash to hopefully move you to the questions here. But if you send it to OHA hospital staffing, we may not see it. So please send it to the all caps questions here because we want to be able to answer your questions.
So we had a question about whether PAs, physician assistants, and NPs, they may be called physician associates now in the law, are considered professional staff. And again, because it is hospital by hospital based on the collective bargaining agreement, or if there isn't a collective bargaining agreement, the hospital CEO, they may be, those kinds of staff may well be professional technical staff, or they may not be. It is really going to be hospital specific.
I see a question about what is the arbitration procedure for professional technical staffing and service staffing? So that is referring to an arbitration procedure that is in place for nurse staffing and those nurse staffing plans. A similar mechanic does not exist for professional technical staffing and service staffing. My understanding is once impasse has been reached, there's deliberations of, I think it can be extended up to 120 days.
Yes.
And then after that, the CEO takes into account the discussions that have been made by the committee and chooses the part or parts of plans that are under dispute.
And just to be clear, that the creation of arbitration or not, or the lack of arbitration was not an OHA decision. That is actually in the statute that was negotiated by the bill negotiators, which were representatives of the unions and representatives of the hospital association. So that's not a choice we have or can make. The arbitration is within the nurse staffing law, and then is absent in the professional, technical, and service staffing laws.
We have a question about what does the complaint process look like? So we have a very long answer, and about an hour long answer for that as a webinar right now on our website. So I'm not going to go super in depth into that. If you want the long answer, you're welcome to watch it on the website. It talks mostly about nurse staffing, but you will see it's very similar for professional, technical, and service staffing. In essence, we are complaint driven, so we will receive complaints. We look to see if they are valid, meaning we can investigate, or invalid, as defined by the law, meaning we cannot investigate.
And so we can only investigate those kinds of complaints listed in ORS 441-792.
Once we have that determination, once we know it's valid, we have 30 days to start an investigation. We start the investigation. The hospital has 20 days to provide documents. And then we review those documents provided. We might ask for more to be able to determine whether there's a violation. And then we provide a report, and that report goes to the hospital administrator. For nurse staffing, it goes to the chief nursing officer. And for all types of complaints, it does also go to the staffing committee co-chairs. So both the staff co-chair and the manager co-chair, and it's posted on our website. So that's the Spark Notes, or Spark Notes version of it, but there is an hour-long explanation on our website under the complaint webinar if you want more detail.
And I would note, when we say it goes to the co-chair, if it's a hospital nurse staffing complaint, then it's going to go to the nurse staffing co-chairs. If it's professional technical services complaint, then it's going to go to the professional technical co-chairs.
And also the union representatives.
Yes.
If the complainant is represented by a union, it goes to the union who represents the complainant.
Or if the complainant is not a union member, but that position is generally represented by a union, it will go to the union. We don't look at individual union membership. We just look at, is there a union representing that group of workers or that kind of staff?
And there is a question of whether that is different for union and non-union hospitals, the complaint process. The complaint process itself and the investigation process, that is all the same. The only difference is if there is no union. If it's a non-union hospital, then there's no union to send the report to. So,
and we know at some hospitals there are some kinds of staff that are unionized and others are not. We would only be notifying the union if the union is representing that kind of staff member. We have a question about whether there are state standards for staffing in labs. And again, we're not enforcing a ratio in labs, except to the extent that that is adopted and approved in the staffing plan. We're not using an external standard here. We're looking to that staffing plan, and that's what's enforceable.
And of course, your staffing plan can't override or exempt you from any other laws that may be governing that area or unit that you normally have to follow. So you don't get out of any other laws by having a staffing plan that says, well, we're doing this other thing.
We have a question about for those with locations outside the hospital, like clinics, how do we know who needs to be included in the staffing committee? So we know that there are hospitals and health systems that have external buildings, sometimes on the hospital campus and sometimes off the hospital campus. The hospital staffing law covers the hospital licensed area, which does include licensed hospital satellites, but doesn't include other associated health system offices that are not covered by that hospital license.
Let me see. It looks like we have, there's a question here that says, when developing a staffing plan, do we outline what happens when there are below standard of employees for a department? So this is getting into, I think, a couple different areas. Your staffing plan, as we discussed earlier, for it to be enforceable, it needs to discuss those enforceable language. Like we're required to have, if there's this many patients on the unit, we're required to have this many professional technical staff members, for example, or we need this number of people on these days from these times, no matter what. Things like that. What you could do is you can always build in provisions that say, well, if this thing happens, then we do this thing. But if you're building in those provisions, that means that you have now built in another staffing level that you can build with your plan, and that's still acceptable as long as you meet that provision. So when we're doing an investigation, we're always looking to say, what is the required staffing level? Are there conditions for that staffing level? Like the one that I'm used to is because I'm so tuned into nurse staffing, like there's going to be 9 patients on the unit, we need 3 RNs and a CNA. And so that it's a condition based off of patient census is what I'm used to seeing. And okay, do they have the 9? Do they have 8? Do they have 10 patients? Different conditions.
It could also be conditional based on day of the week. Certain outpatient services may know, oh, on Tuesdays and Fridays, we have a bigger volume of people coming in, and therefore our staffing is different on Tuesdays and Fridays. As long as that's what's included in the plan and written in language that makes it enforceable, then that's what would be the minimum staffing.
And I'm seeing a lot of questions along the lines of, what is minimum staffing? What does that mean? That is language that means that we see in staffing plans. It's a little bit of an artifact from the 2015 nurse staffing law, when plans were required to have minimum staffing levels. For practical purposes, what it means is we are not going to drop below the staffing level. If we drop below the staffing level, then it is a deviation. We can staff above it, but if we know that if we're dropping below it, it's going to be a deviation from our staffing plan.
And let's talk for a minute about deviations, just because that is built into the law for any unit staffing plan. There can be up to 6 deviations in a rolling 30-day period, and a deviation can last up to 12 hours. And there can be some fluctuations within that 12-hour period. So if your minimum staffing is, we will have 8 respiratory therapists on duty in the west wing of the hospital, and the west wing is defined as a unit. And on Tuesday, we only had 6 respiratory therapists on the 12-hour shift. And actually, we got an extra one who came in for that last hour. That entire time, you still don't have 8, which was required by the staffing plan. And what would happen at that point is the unit manager for the respiratory therapists would need to notify the professional technical staffing committee that covers those respiratory therapists at this hospital and notify them, on Tuesday, we had a deviation. It lasted from this time to this time. This is what it was.
And that notification needs to happen within 10 days of the deviation. So having an internal way of tracking that to be able to make sure you're not missing that 10-day window.
So The hospital can have 6 of those incidents for any unit staffing plan within a rolling 30-day period. And then that would not count as non-compliance for enforcement purposes. We do have a question asking for clarification on what consistent with National Labor Relations Board regulations means and where can we find these regulations? And I will say that is an excellent question. That is actually a question we raised when HB 2697 was being negotiated back in 2023. And we looked at the National Labor Relations Act and we were unable to find lists that define professional technical or services staff. So I think that is still an outstanding question.
There is a question of if there is staffing in a professional staffing plan, technical staffing plan, and service staffing plan, should that staffing also be included in the nurse staffing plan? And so as Anna was mentioning, these are separate plans, they have separate voting, they have separate representation. So we need to make sure that the plans don't conflict, but the nurse staffing plan is overseeing those nursing staff members, the RNs, LPNs, and sometimes maybe CNAs. We can get to that in a minute. And then professional technical staffing plans are overseeing professional technical staffing members. Service staffing plans are overseeing service staff members.
We have a lot of information about CNAs in the hospital staffing special topics webinar we did at the beginning of October. Yes. And so I would definitely refer people to go back to that. But the short story of it is CNAs were included in the nurse staffing law starting in 2005. And the 2023 law includes CNAs in various points within the law as part of the nurse staffing committee, and within nursing staff for purposes of mandatory overtime, and then set the CNA patient maximum assignment and indicated that permitted deviations get reported to the service staffing committee. So there's still some confusion about where do the CNAs belong, but I think the best advice we would have about that is, for clarity, they should be in one place or the other to the extent that they live in both a service staffing plan and a nurse staffing plan. If that language between those two staffing plans is in any way in disagreement, there could be enforcement problems.
And for all of those staff who aren't CNAs but are professional technical service, they should be in their own respective plans. Each group, if you have your own committee, that's what your plan should be addressing. The professional technical, for example, shouldn't be putting nursing in there. Nursing shouldn't be putting professional technical into their plans. That may complicate enforcement and investigations, and follow the committees and plans and representation that oversees each different group.
And I will note that just as professional, technical, and service staff are all defined in the statute, that same statute that defines those defines direct care staff as RNs, LPNs, and CNAs. We know there aren't a huge number of LPNs working in hospitals in Oregon, but there are some, and they are covered by the nurse staffing plan.
And it hasn't, it's not something that we would enforce as a requirement, but you may for your own purposes find it helpful for organization to have those staffing plans list. These are the staff who this covers, especially for professional, technical, and service, as they can vary from one hospital to the next.
We have a question about whether there is a template that OHA has for staffing plans to be drafted in. We don't have a template. If we were to put out a template, we would then be requiring people to use that. And what we say is the hospitals are in the best position to know what their staffing plan should look like. There are some hospital systems that use a template and use it throughout their system, and there are other hospitals that don't.
I see a question about are alternate staffing committee members required? I think that's relating to those staffing committee operations. And what we've seen with nurse staffing and those nurse staffing committees is that some hospitals choose to have alternates, substitutes essentially. So if you have a primary member who's on vacation, they might have an alternate who can come in and step in for that individual. Alternates are not required, but that is something that hospitals do. Yeah, you'll see it for nurse staffing too, but some hospitals do it, some hospitals don't, and it's not a requirement.
Under the old law, that was something that we suggested, that if hospitals were going to do it, they reflect it in their charter. I think that helps clarify what's going to happen, when will alternates be used, and the selection process for those alternates, which really should mirror the selection process for the committee members. But we really don't have authority over that level of committee operations at this point.
So there is a question about what happens if the plan, so assuming professional technical and service staffing plan is not submitted by December. So as Anna mentioned, we do take action on complaints about things that are some complaints that are submitted to us that are under ORS 441.792, and we do talk about that in a bit of a different webinar. As it relates to this, it's about a failure to create a plan for professional, technical, and service staffing, failure to follow the plan, failure to release a staff member, and failure to release a staff member to attend the staffing committee meeting. I abridge these in my brain and then realize as I speak aloud, I will need to expand it for people. The last one is failure to establish a staffing committee. So that's what we can enforce related to professional, technical, and service staffing. I'm expecting, just like we had with nurse staffing and nurse staffing plans, in nurse staffing, they were required to update their plans and have plans that are compliant with the new law in place by June 1st of 2024. And we had a flood of new plans the last week of May, excuse me, which meant there was a delay in putting those plans on the website because we only have so many people. I imagine we will have that same thing in December as more professional, technical, and service staffing plans come into place. That is going to be double in size because we have 2 different types of plans for each hospital, and that is the holiday season. So we will probably have a little bit of a delay getting those in. It's not a violation for it to not be on our website. So if you're seeing it there and it's like, well, it's not on the website, that doesn't mean the hospital didn't submit it. It doesn't mean that there isn't a plan. And so that's a different situation than failure to have a plan.
Yeah, there isn't a violation for didn't submit it to OHA. It's a requirement that hospitals submit it to OHA, but we have no enforcement authority over that. So if a hospital has adopted a plan, we will come and investigate a complaint about whether or not they adopted a plan, but merely not submitting it to us is not something we can take any enforcement action on.
And if you already have those plans, please do get them into us early. We would love to avoid that last minute holiday rush on plans at the end of December, but you do have until December 31st.
We have a question about what rules apply to SICF, Special Inpatient Care Facilities. That is a type of hospital in Oregon, and the only facilities currently in that category are inpatient hospices. Because they are technically a kind of hospital, all of these rules apply to them. All of the statutory requirements for hospital staffing apply to the inpatient hospices, just as they apply to any other hospital in Oregon.
We do have a question about listservs, and I'm not sure if Anna, you might have an answer about this, but they know this question says that they know there's a nurse staffing listserv. Yes. Will there be separate listservs for professional technical staffing and service staffing one day?
I am certainly hopeful, but there's no harm in signing up for the nurse staffing listserv in the interim. You can also just sign up for the hospital listserv. When you sign up for any of our listserv, you'll see a menu of all the different ones you can sign up for. And I will say, we don't put out a lot on the listserv. We aren't spamming you every day. So it is worthwhile to sign up, because that's where we announce things like updates to the FAQ. We do have that live on our website already. Webinars and other, sort of in the moment announcements, but we don't send out a whole lot. So I would like to see us have a professional, technical, and service staffing, two more listservs. But it makes sense to sign up for the hospital staffing one at this point to make sure you're getting the information. And when we get new listservs, we will announce it there.
We have a question. If we combine our professional technical staffing committee and service staffing committee, do we need co-chairs for each of those, or can there be one co-chair for the combined?
No, you actually do need to have the co-chairs for each of those. That's still in the statute. They each still have to have their own co-chairs. I do want to touch on, and we didn't do a slide on this, but I want to touch on meal and break, because that is sort of a subset of complaints, and meal and break violations are listed in the law, but they're not investigated by OHA. Those are investigated by BOLI. What the law said was you can file your complaint with OHA or with BOLI. If you file it with OHA, we send it directly to BOLI, and BOLI may still require you to complete their complaint intake form, which is different than ours.
That's my understanding for all of the complaints that have been submitted through our route, is that all of those individuals, if they do have a complaint that is under their current jurisdiction, you would have to resubmit the complaint form. So you do have that extra layer, that extra step of time still, because you're still having to complete another form.
So if you want to file directly with BOLI, we've actually put the link where we have information about filing a complaint with us. We've also put the link directly to the BOLI page that takes you to their complaint landing page, so you could file directly with them. And that's available on both healthoregon.org/nurse staffing and healthoregon.org/facility complaints. Both of those have the same information about filing a hospital staffing complaint and the direct link to file directly with BOLI.
And we're not BOLI, so I can't get into it too much. I'm not as familiar with their statutes, but I do know that their requirements don't go into effect until June 1st, 2025, those new hospital staffing. So right now they're operating under the statute. They had free hospital staffing. Their things don't go into effect until June 1st, 2025. And I believe there are limitations on what actions they can take if you are represented by a union.
Yes, my understanding is that until June 1 of 2025, if you file a complaint about a missed meal or break and you are represented by a union, they will refer you back to your union to resolve that. So we have a question about whether a hospital can have a steering committee that is made up of management that is somehow over the hospital staffing committee, either professional, technical, or service or nurse staffing committees. And while a hospital may have a steering committee, the hospital is responsible for implementing the plan that is approved by the relevant staffing committee. So if it's approved by the professional technical staffing committee, the steering committee could not then choose not to implement that approved plan.
It's similar to how some hospitals might have unit-based practice councils. You're able to have that, but that does not negate whatever approvals come through the nurse staffing committee or professional technical staffing committee or service staffing committee. And I do see, I know we touched on this already a little bit about outpatients, but I am seeing questions about how required staffing or minimum staffing works for a unit that does indeed close when there aren't patients present, or holiday schedules, lunch schedules.
Mhm.
And I think I'm remembering seeing that sometimes for ORs, for example, for nurse staffing, that you would include that in your plan as this is a thing that happens on our units. These are the times and periods that happens, and we're not going to have patients here. We're not going to have a staffing requirement for that time.
However, if you have that sort of procedural unit where you then have patients come in the morning, let's say it's a short stay unit, you come in, you do the procedure, and they are there over the lunch hour, but you're not bringing in new patients and not doing new procedures, but you still got patients in the PACU, then what you would do is include in your staffing plan, okay, well, we don't actually start new procedures during this time, so the staffing should be this instead. Because somebody still needs to be there to provide care for those patients while you're not taking in new ones, but you still have the old ones around.
And I also see a question. It's about the nurse staffing overlap with the professional technical staffing plan. A couple of different unit types, particularly procedural units, will have an overlap where the scrub tech, there is a scrub tech, but an RN can step in and fill that role, and how that would be represented in both staffing plans. I think this is an example of making sure those staffing plans aren't in conflict with each other.
And we had a question about whether this law was intended to ensure access to care and not ideal care. And what I would say is the staffing plan that's approved is the one we enforce. So whether that is the absolute minimum of staffing, or whether the minimum is somehow more than your bare minimum, that's up to the staffing committee to approve what the staffing committee can approve. We can only enforce what's in that plan and what is described as required in that plan.
So if you describe it as an ideal staffing level, that's not going to be something that's required in most situations when we look at most of those staffing plans. What you can sometimes see in there is if you're wanting a minimum and an ideal, we'll sometimes see hospitals put in and say, this is our minimum. We're not dropping below that. If we drop below this, it's a deviation, but this is what our goal is. And we want to make sure that we staff, at least 75% of the time at or above this ideal level.
So we would, in that situation, be able to enforce the minimum, but not the ideal.
Yes, exactly.
There are plans that list both of those, and we can enforce the one that's described as the required, the minimum, it doesn't go below this.
The minimum number, the maximum patient assignment, if you're doing ratios, minimum, maximum, required, staffing levels, shall or must, mandatory, all of those more the firm words.
We have a question about whether an EMT department falls into these staff types, or would they fall into the nursing plan? So I'm a little confused about this. And what I would say is a couple different answers. One is, I'm not sure if we're talking about emergency medical technicians working in an ED. If that were the case, again, you would look to the collective bargaining agreement. Are these and then if there's no collective bargaining agreement, look to the CEO for that determination. But if we're actually talking about an EMS service that's run by the hospital, that is a separately licensed service. And so that would not be covered by the hospital license. There are some rural hospitals that run their own ambulance system. And so that would be a separately licensed non-hospital service. Similarly, there are some hospitals that have licensed ambulatory surgery centers on their campus. It's a separately licensed ambulatory surgery center. It's not the same as the hospital's short stay or day surgery. That ambulatory surgery center is not covered by the hospital staffing law. So we would not be enforcing any staffing requirements at an ambulatory surgery center under this law.
Yes, this is a hospital licensing law. It's tied to the hospital's license. So if it's covered under the hospital's license, that is an area in theory that could have a nurse staffing plan or professional technical staffing plan or service staffing plan if they have those types of staff members there. Another one that I can think of is that some hospitals have outpatient hospice associated with them. And I know that's also for inpatient hospices, the inpatient is licensed as a hospital, the outpatient is licensed as a hospice. So the inpatient is subject to the hospital staffing law, the outpatient is not. For the hospice specifically.
Yes.
If the outpatient clinic is covered under the hospital license, might still be subject to the hospital staffing law.
We have a question about whether hospitals are including IT, their information tech or information services in their staffing plans. That really is, again, up to, it's based on that collective bargaining agreement. And if it's not a union situation, then it's based on the CEO. IT could absolutely be included in professional, technical, or service staffing, depending on that collective bargaining agreement or the CEO.
And there is a question as well about, are there examples of these staffing plans? And we will have these on our website as hospitals are submitting them. We do have just recently, one hospital submitted a professional technical staffing plan, and I am planning to get that posted today. So there should be, there's examples of nurse staffing on there. We'll have at least one example of a professional technical staffing plan on there soon. We haven't received any service staffing plans yet. But again, I encourage you, avoid the holiday last minute rush. It's just like that holiday shopping, get it done early.
I would also note, so we are posting these plans, we don't endorse them, we don't say that they are compliant or valid, we are just saying we received it, we're required to post it when we receive it. We do have a question about whether there, again, about whether there's going to be additional guidance on staffing plans. The guidance is in the statute. We do have available on our website an FAQ. It was most recently updated in September, and it has the guidance that we can give about this law and different aspects of it. And I will also note we have, again, the staffing plans posted on the website. We also have all of our complaint investigations that we've completed posted on the website. So those are also a good source of information if you want to see what kind of language we can enforce. That is a good way to look in those reports, because you can see we tell you what the language was in the plan and whether or not we can enforce it.
I see a question as well about how in some settings, there are managers, so professional technical managers or service managers who can step in to provide patient care to prevent staff from going over their maximum capacity or dropping below numbers. And it asks if that is, if they're not allowed to do that anymore, if that should be avoided. We can't speak to whether to do or not to do. There's no requirements related to that. And I will say for some critical access hospitals in particular, with nurse staffing, we have seen nurse staffing plans that say, well, managers can help cover managers. And when managers are providing patient care services, acting as a direct care nurse, they would count to the staffing requirements.
What we would look for is for the staffing plan to talk about this can happen and this is what should be happening. So the staffing plan would have to say, yes, this person counts towards this minimum number or towards this ratio or however minimum staffing is represented
in these situations.
Yes.
It's one of those provision things I mentioned before of if this thing happens, then this is the staffing. And I will do a time check for us, Anna. We're already at 11:03. Time has really flown, and I know that we've got questions and questions still.
So I would say we will continue, but we do understand if people need to hop off, and we will record this. So these answers that we give will still be available on the recording, and you can always skip over the part you've already heard or listen to it at a faster speed.
So I see a question that again, it's for those outpatient services where that it's asking when patients have to be rescheduled because staff are not available, is that a deviation? And so a deviation is about staffing levels. So do you not have the number of people you need in this situation? It really doesn't get into whether patients are being rescheduled or what you're doing in response to expected staffing levels.
But if you, let's say you're dealing with an outpatient unit, you expected to see 30 patients today, and it turns out you're short-staffed, and so you reach out to those patients and you say only 15 can be here. And now you have enough staff to cover the patients and comply with your plan, then that would not be a deviation if you then didn't have the patient volume that required the higher level of staffing.
I think that does get us into an important point and one that we talk a lot about in the complaint webinar about future complaints. So these are complaints that are anticipating a potential violation, but the problem hasn't happened yet. Those complaints are invalid. We triage those as invalid because it's not reflecting that there's been a potential violation that happened. And the hospital still has the opportunity to correct the situation, either by calling in more volunteers to come in, or I suppose in this case, rescheduling some patients.
Which in some, in some departments, that is more of an option.
Yes.
Versus in other departments.
Yes.
We have a question about optimal versus minimal staffing and safe staffing. And again, what if you write it as optimal in your staffing plan, we're unlikely to be able to enforce it. What we really need to be able to enforce is language about what's required. So we know that hospitals often come up with what is their optimal staffing, and you can include that in your plan, but when you put in optimal, that's not what we can enforce. So we would then say, okay, where in your plan is the minimum?
There's a question about how the deviations from the staffing plans work. So for the deviations in a rolling 30-day period, is this a unit specific thing, or is it for the whole service and professional technical plan? So the deviations count for each staffing plan. So if your professional technical services, if that for the entire hospital is under one plan, that
and
would
one unit.
Yes, if that's going to be that's your 6 deviations. Now, if you do a bunch of unit specific plans, which we see quite often for hospital staffing, or I mean, excuse me, nurse staffing, then each unit would have its own 6 deviations. But you have 3 different categories. You still have those 6 for the nurse staffing, the 6 for the service staffing, the 6 for the professional technical staffing.
And I see a question there about, would it be allowed to have 2 people voting on a staffing plan for staffing plan approval? And again, as long as you have a quorum at the meeting and equal numbers voting, if those 2 people represent a staffing committee member and a manager staffing committee member, that would be a legitimate vote. That would be an approved plan if both of those people voted to approve the plan. If one voted to approve and one voted to not approve, well, then you don't have an approved plan.
And we don't oversee the operations as much anymore, but I know with nurse staffing, especially during the pandemic, it started being, well, we can do this remotely. We want to make sure there's a way for people to get here. And I cannot right now recall if professional and technical and service, that's still also, I don't think it requires you,
I don't
be in person.
There's no requirement in the law that it be an in-person meeting. So as there would need to be some way of confirming that, yes, these people are meeting, and this meeting occurred and these people voted, but it could be a meeting that's on Teams or
Zoom
or
Skype if
yeah,
still
that
use
still
Skype.
exists.
Oh, so we have a question of if a staff member has a complaint, does it go directly to OHA or does it get filtered through the staffing committees first? So any of those complaints that are filed through our website go directly to us, and those are confidential to the extent allowed under the law. If you go first to your staffing committee, we don't have a mechanism to see that. And then if you go first to us, we're not providing that to your staffing committee. Those are separate processes. And there's no requirement in it, though, that you have to go to your staffing committee first and then us.
There's nothing that would prevent you from going to your staffing committee, but just going to your staffing committee doesn't mean that it gets filed as a complaint with OHA. We have a question about what is the meaning of the term access when coming up with a plan and ensuring patient access to care. That is not defined in statute, so that is a great question. It's not defined in statute, and OHA has very little rulemaking authority for this law, so that is not something that has been defined. And I would say that's something for the staffing committee to consider. What is access for patients?
And that is also related to those other terms under the annual review for these plans. Those also have each of those features that need to be considered for the plan has not been defined by the statute. And as Anna mentioned, we have very limited rulemaking authority. Okay. So I'm seeing it's 11:10.
I would say 2 more questions.
Yep, that makes sense to me.
Okay, I see a question about how are departments and facilities held accountable? So the staffing committees are really self-regulating. OHA can investigate if there isn't a staffing committee. If no staffing committee has been established for professional, technical, or for services staffing, we actually don't have the authority to investigate if there's no nurse staffing committee. But in terms of committee activities or ensuring that committees pass plans, OHA really doesn't have the authority to enforce that. What we do have the authority to enforce is if there's a complaint that this hospital doesn't have a plan. And so if we got a complaint like that, we hold the hospital responsible because the hospital is the one with the license. But in terms of holding committees accountable, we have really limited authority. We can investigate the specific complaints that are listed in that statute. And Kimberly, do you want to pick the last question?
I'm looking through our list.
And I will note while you're selecting a question, even if we don't get to answer your specific questions, we do look at these questions when we are looking to expand our frequently asked questions, because we see certain questions come up over and over, and that is a signal to us that that's something we would like to get an answer in writing and make that available.
I do see a question here of it's referencing some of our comments earlier on how we don't review plans for compliance when they're getting submitted. We're not providing feedback on plans. So it's asking, is it possible essentially for a committee to approve a plan that doesn't have language enforceable by OHA? And I would say that that's been something that we've seen actually quite a bit for nurse staffing. And so if you look at a lot of the nurse staffing reports that March 2024 that are currently on our website, there are a significant number where we say, well, this language isn't enforceable. This component is, but these other things are not enforceable. And so our reports, the final investigation report, will call out if there is language that is unenforceable in there, that to try to help make it clear, like we weren't measuring to this thing, but we did measure to this. But yes, it is absolutely possible that a staffing committee may pass and approve a plan that doesn't have any language in it that we can enforce.
And we don't look at all of the elements of a plan. We look at the aspects that we are able to enforce. So whether staffing whether the staffing plan includes minimum requirements for the number of staff or ratio for the number of staff to, a patient to staff ratio. There may be other elements that are put into a plan that are requirements of that plan that we would not be able to enforce, and we wouldn't be reviewing those as part of a complaint investigation. But it does absolutely happen that staffing committees approve plans that are not enforceable or not compliant with the law. We don't have authority to go and investigate and say this plan is not compliant, you need to make a new one.
And that's why it's so important too to be aware of the language that you're using when you're drafting these plans. Are you using the left-hand side of that column, the required minimums, maximums, mandatory, that firm language? Or are you doing something that's a little more, I keep wanting to say wiggly. I'm moving my hand, no one can see it. I'm trying to think of the word for that, but we can foggy, yes. Vague, there we go. Because we can enforce required language that says this, we must do this. Things that are guidelines or ideals or core recommendations, guidelines. These are the national guidelines. It might be a national guideline, but it's a guideline. It's not a requirement that you put into the plan.
But you could adopt it and
As a
say, this
requirement.
is required here. We take a national guideline and we make it a requirement here, then that would be enforceable. I have flipped to our last slide, which links to our website, or it shows you our website, our email box, the complaint form where that's linked, and also information about where to go for information about meal and rest breaks on the BOLI system. So with that, we will thank you for joining us today, and do sign up for the listserv because we'll let you know when we're going to have another webinar and other resources that we'll have coming soon on our website and sent out through that listserv.
And do please use that link with the test forms. Fill out those test forms. Let us know how that works, or if there's anything weird or confusing or broken in the form.
Thank you.
Thank you.